Everybody, and welcome to today's webinar on neoadjuvant chemotherapy, which is going to be spoken on by Dr. Vijay Aggarwal. As you know, we've been having bi-weekly webinars every week. Let me just begin sharing my screen. One moment. So we've been having two webinars every week on Thursdays and Saturdays. We are into our second module on the cancer of the oral cavity. And we've had some wonderful speakers join us from all over the world, in fact, and all over the country. And we have about 3 more talks lined up in this module, after which we'll be following it up with the module on reconstruction. So we have, as you can see, a few more webinars coming up in this module. Parallelly, we are also running the minimally invasive head and neck surgery COMED series, which is the continued online medical education series. And we had we've had 3 so far, 2 on transoral laser surgeries, and the last one was on robotic surgery. And this Sunday, that is the 26th of July, we're going to have the second module on robotic surgery of head and neck. So please join in for that. We have reputed international and national faculty joining us for this as well. These webinar series have been possible only because of the help of our Academy of Head and Neck Oncology of Karnataka, which is affiliated to the Asian Oncology Society. The Academia helps young head and neck surgeons, budding head and neck surgeons, to connect with one another. And it also has a lot of other facilities available, which you can avail by becoming a member. Please write to info@ahnok.com for more information. So, of course, nothing can be possible without our team. My senior colleagues, Dr. Ravi Nair sir, Dr. Vishal Rao, and Dr. Akshay Kurpaje are the ones that have been guiding us from the start. And, they've been helping us out. And Dr. Akshay Kurpaje started this entire webinar series with the first module. Dr. Anand Subhash, who's been handling the social media platforms. Dr. Bhargav, who's always been working in the background with the technical aspects and hosting the session, and Dr. Ritvi Bagadia, who's helped out with the oral module, have all made this possible. So thank you, everybody. So coming to today's webinar, I'm happy to introduce who's joined us all the way from NDR Cancer Center at NACT. Welcome. Is a consultant head and neck surgeon in the Department of Surgical and Center. He is a member of Edinburgh. He is a fellow head and neck surgery from Malabar. He's been at and he has reputed and he's also Dr. Sudhir.
Yeah. Hi, sir. I think Dr. Shalini's bandwidth is a little low. I think it got broken.
I'll just briefly introduce Sudesh because there was a little break. So Sudesh, as Shalini just mentioned, he's a head and neck surgeon practicing in MBR Cancer Center. He is a good friend of mine. We worked together at MBR when I started my career in head and neck at MBR Cancer Center. So we had a very good time. With that little introduction, just hand over the screen to Dr. Sudesh to introduce the speaker for the day.
Yeah, thank you, Akshay and Dr. Shalini, for your kind words. Very good evening to you all. Dr. Vijay Aggarwal actually doesn't need a much introduction in this field, but to complete the formality, I should say a few words about him. Dr. Aggarwal completed his undergraduate medical training from JN Medical College, Belgaum, and subsequently his MD in medicine from Manipal Academy. And he completed his specialist training in medical oncology from the United Kingdom and pursued his MRCP as well. Later, he practiced as a consultant in medical oncology in the University Hospital, Birmingham. Then the PhD, his PhD from the Holyoke Medical School, the United Kingdom, shows his keen interest in the field of cancer research. And he has published many papers in various peer-reviewed international journals. And he has a vast experience of over 12 years in the field of medical oncology. And he is currently practicing as a senior consultant in medical oncology at the Aster CMI Hospital, Bangalore. I welcome Dr. Vijay Aggarwal to enlighten us with his knowledge and experience in neoadjuvant chemotherapy in oral cavity cancers. Over to you, Dr. Aggarwal.
Thank you, Sudesh. Thank you for those kind words. So I'm going to talk about chemotherapy to surgeons. She's never a good idea. And Shalini conned me into doing this. But essentially, what we're going to talk about is I don't have any pictures or to show you of surgeries. All I have is data, and more data. But what I'm going to do today is give you an unbiased view of the role of chemotherapy, what the surgeon needs to know essentially. What you need to know is when you get a patient, and if you want to think about, shall I operate or shall I talk to someone about chemotherapy, I think this will give you a good understanding of when you want to think about chemotherapy. And by and large, ideally, all patients should undergo through a multidisciplinary team meeting, which has a medical oncologist, a radiation oncologist, and a surgeon as a part of the meeting to make decisions. But essentially, we'll whip through over the next 40 minutes or so about the role of neoadjuvant chemotherapy. And I'm going to limit my talk to oral cavity cancers only and not talk about the rest of the head and neck cancers. Can everyone hear me? Okay.
Yes, sir.
Yes, sir, we can.
So this is going to be the outline of my talk. We'll talk a little bit about the introduction, the role of neoadjuvant chemotherapy in resectable oral cancers, in unresectable oral cancers, in borderline resectable oral cancers, and a brief summary of the talk. So let's talk a little bit about the introduction. Now, all of you have seen this, isn't it? This is the Globocon data for India. Okay. And when we look at oral cavity, I'm not even talking about head and neck cancer, I'm just talking about oral cavity. Amongst the men and women, so all sexes, it constitutes about 10% of all the cases, which is the second highest in India. Now, when we look at the men, it is the highest, which is about 16% of all cancers are oral cavity cancers. And in women, it is about 4.8%. So what I'm trying to say is that compared to the worldwide figure, okay, where oral cavity cancers does not even factor, it probably is lumped with the other cancers. In India, it is a big, big problem. Okay, and the solutions have to come from us as well, not from the West, because they don't see that much and they don't have that much experience. But oral cavity cancers in India is one of the highest in the world, and we have, like I said, more than our fair share of oral cavity cancers. And in India, the cancers, the oral cavity cancers, essentially presents at a much later stage. So if you see in stage 1 and 2 in India, which is published by Singh et al., stages number 3 is 28% and stage 4 is 64%. So the vast majority, okay, which is about more than 90% of the patients, present at an advanced stage, which is stage 3 and 4, compared to the United States, where it is only about 35% presents at stage 3 and 4. So we have a much higher burden of oral cancers who present at a much more advanced stage than other people. So what is the standard of care? What is the standard of care for those patients who have oral cancers? Now, we know from historical studies, and all of these studies are quite old now, but from historical studies, we know when we compare surgery and adjuvant radiation versus chemo-RT, surgery followed by adjuvant radiation always results in better outcomes in terms of overall survival, okay, as well as progression-free survival. Okay, so these are some of the data, some of the studies, and I'm not going to delve into all of these studies, but essentially, based on the studies, we know that the standard of care for oral cavity cancers, if resectable, is surgery, followed by chemo-RT if required. So where does induction or neoadjuvant chemotherapy come in? So what we mean by the word neoadjuvant chemotherapy is basically chemotherapy that is given before a definitive treatment. So in situations like oral cancers or head and neck cancers, the definitive treatment is usually surgery, radiation, or chemoradiation. But what we mean by neoadjuvant chemotherapy is a chemotherapy that is given before a definitive treatment. Now, there are some of the facts on neoadjuvant chemotherapy, and I'm not going to talk about data or these facts, but this is something that we have to know, and you just have to trust me that these are true. Okay. Now, if we are able to give drugs optimally, head and neck cancers have a very high response rate to chemotherapy with transient toxicity. It does improve nutritional status and performance status of the patients once they start on chemotherapy. We know that it has established role in organ preservation strategies, particularly around the laryngeal cancers. Okay. And giving neoadjuvant chemotherapy does not necessarily compromise subsequent definitive treatment, either that be surgery or radiation. We also know that response to induction chemotherapy predicts response to radiation, in such that patients who respond to chemotherapy tend to also respond to radiation therapy. Early institution of systemic therapy can possibly deal with early occult disease. Okay. The historical standard based on which some of the benefit has been shown, particularly in the McKenzie analysis, is the 2-drug regime, which is a platinum and 5-FU regime. However, since then, a 3-drug regime has come, which is a taxane, platinum, and 5-FU, which is probably more efficacious and less toxic compared to the higher dose of PF. Now, let's talk about McKenzie analysis. We know no talk is complete without first addressing the data for McKenzie, and I'm sure all of you are aware of this data, which was initially done in 2000 and then subsequently updated in 2009. Okay. So the McKenzie analysis was a pooled individual patient data analysis from 93 trials involving over 16,000 patients. Okay. And essentially, when we look at the role of chemotherapy in that, chemotherapy can be given concomitant with radiation, as an induction, or with adjuvant. And the only benefit we see based on this forest plot is with concomitant. We don't see any benefit with induction chemotherapy, nor with adjuvant chemotherapy. Okay. But most of the chemotherapy used in this study, when we're talking about induction chemotherapy, were 2-drug regimes and not 3-drug regimes. And with concomitant, it was essentially platinums. Now, when we compare concomitant with induction, the benefit across all groups, whether it be overall survival, event-free survival, or locoregional failure, they're all in favor of giving concomitant chemotherapy rather than induction chemotherapy. So based on this, clearly induction chemotherapy kind of went away, and concomitant chemotherapy along with radiation became the standard of care. And we can see from this that the absolute benefit, okay, from concomitant chemotherapy is about 8%. So for medical oncologists, anything that has more than a 5% benefit, we jump at it. Okay, and this is giving 8% absolute survival benefit, okay, which was statistically significant. So I think based on this, the concomitant chemoradiation has become the standard of care as opposed to induction chemotherapy. Now, let's not forget that the McKenzie analysis was for all head and neck cancers, not just for oral cavity cancer. So let's draw attention to the neoadjuvant part of the oral cavity, and you can see that the hazard ratios are 0.93 and 0.94, okay, both for overall survival as well as event-free survival. And there's absolutely no benefit. There's absolutely no benefit. The benefit is about 2% in this and about 3.8% in the PFS benefit. So there's absolutely no benefit in giving neoadjuvant chemotherapy in oral cavity cancers for this group of patients as per the McKenzie analysis. So let's talk about resectable oral cancers. Okay, so you have a patient who's come to you and you've seen a oral cavity tumor which looks resectable. Then obviously the question is, well, I can operate, but then do I want to now give chemotherapy? And does that improve outcome? So let's talk about a couple of studies. The first ever studies looked at giving induction chemotherapy to operable oral cavity tumors was by the Reseetable in 2003. Okay. All advanced resectable oral cavity tumors were included in the study. It was a multi-center randomized phase 3 study of T2 to T4 tumors, N0 to N2, previously untreated oral cavity tumors. So 198 patients recruited into this study, and they were randomized to 2 arms. One was the chemotherapy arm. They were given cisplatin and 5-FU, followed by surgery. The second arm was surgery only. Radiation was given to the high-risk patients. In this study, the chemotherapy was given
Vijay sir, your voice is not clear.
Vijay sir, we seem to have lost your audio completely, and your video is also black. I mean, dark. Okay. I think Dr. Vijay Aggarwal has gotten disconnected. We'll just wait for 2 minutes for him to join back. So just to inform everybody in the audience that this video is streamed live on Facebook, and all our videos up until now are available on our YouTube channel, HCG Academics. The name of the channel is HCG Academics. So please subscribe so that you receive regular updates regarding the upcoming videos.
Hi, Shalini. Sorry, I'm back. The light went off. Hello?
Yes, sir. Yes, sir. We can hear you now.
Sorry, can you let me share my screen again? Sorry.
Yes, sir. Yes, sir. One moment. Bhargav, can you make Dr. Vijay Aggarwal the co-host again?
No, I'm not able to share my screen.
I think you should be able to share.
No. Host disabled participant screen sharing.
Bhargav?
No, I'm not able to share my screen.
And you are a co-host. I think you can. You're not able to, sir.
No, I'm not able to share my screen. Oh, can you make me a host?
Just a second, sir. Just a second.
Sir, can you try once more, please?
Yeah, I can share it now.
Hello, sir. Your bandwidth is low.
Okay. Yeah. Hello?
Yes, sir. Yes, sir. We can see your screen now.
Can you see my screen? Okay. So I think I was talking about
Sir, what we can't see your screen again.
Hello?
What may help? Sir, what may help is perhaps if you switch off your video, your network availability will increase.
Hello?
Yeah, sir, I'll just call you once.
So I'll stop my video?
Yes, sir. Please stop your video.
Okay, I've stopped my video. Sharing my screen
just share your screen. That's all.
Okay.
Just a second, sir. It's coming. It's not yet come completely.
Can you hear me now?
Sir, we are able to hear you, but it's all broken.
It's a little patchy, sir.
Okay, just give me 1 second. Okay, just give me 1 second. Okay. What about now?
Yes, sir.
Is it better now? Okay.
Yeah, now it's a little better, sir.
Okay. So sorry about this. The electricity went off, so I'm on my mobile, but It's back on now. Okay, so we're going to talk about neoadjuvant chemotherapy in resectable oral cancers. Okay, now the first study was done by Reseetable in 2003, which was done in advanced oral cavity tumors, which is a phase 3 multicenter trial in locally advanced oral cavity cancers in about 198 patients. The patients were randomized into 2 arms, which was induction chemotherapy with cisplatin and 5-FU. And the second arm was surgery only. Okay. In this study, cisplatin was given at 100 milligrams per meter square and 5-FU at 1000 milligrams per meter square over 120-hour, over 5-day infusion. Now, let's not forget that this was a 2003 study where ondansetron was very, very expensive and possibly not given routinely to all our patients. Okay. Keeping that in mind, 100 milligrams of cisplatin is actually quite toxic. Based on that, only 64% of the patients completed the planned 3 cycles of chemotherapy. 37% of the patients had grade 3-4 diarrhea, and 3% of the people, 3 people had died because of chemotherapy. Now, the outcome was essentially there was no difference between the induction chemotherapy followed by surgery arm versus the surgery only arm, and the 5-year overall survival in both the arms was 55%. However, there were some benefits seen in the Reseetable trial. In those patients who received induction chemotherapy, mandibular resection was performed in less number of them. So there were only 31% of the patients needed mandibular resection in the chemotherapy arm versus 52 in the surgical only arm. And even less number of people who received chemotherapy needed radiation, which was 33%, as opposed to 46% of those patients who did not have chemotherapy. So there's some benefits seen, but there was subgroup analysis. But the clear-cut, the major benefit, which is overall survival, was not seen in either of the 2 arms. A subsequent long-term follow-up of the Reseetable trial was presented by Bossy et al., which is 11.5-year follow-up, and that essentially showed exactly the same thing. There was no overall survival or disease-free survival benefit, no local regional relapse or distant metastasis relapse benefit seen in those patients who received induction chemotherapy followed by surgery versus surgery alone. However, it did prognosticate that those patients who received a complete pathological complete response did better as opposed to those patients who did not. So it did segregate the good group from the not so good group. So it does give us some information on which patients are likely to do well as opposed to not, but that is not a reason to put someone through chemotherapy. Another study, which was published in JCO in 2013 by Zhang et al., looked at some patients, which was advanced resectable oral cavity tumors. Again, it was a phase 3 randomized trial of 2 groups, induction chemotherapy followed by surgery versus standard surgery alone, 128 patients in each group. So in this group of patients, a 3-drug regime was used, which was TPF, but only 2 cycles was used, as opposed to the Reseetable trial, which used 2 drugs for 3 cycles. And these 3 drugs were used for 2 cycles. And even the dose was slightly lower. So cisplatin was 75 milligrams per meter square, as opposed to 100 in the Reseetable trial. And 5-FU was 750 per meter square, as opposed to 1000 as in the Reseetable trial. In this study, 98% of the patients completed the planned 2 cycles of chemotherapy. Only 9% of patients had grade 3 toxicity, and there were no grade 4 toxicity or death because of the induction chemotherapy. When we look at the overall and the disease-free survival, there's absolutely no benefit in those patients who received induction chemotherapy as opposed to patients who did not, in either of the survival curves, overall survival or disease-free survival. When we look at the subgroup analysis on this forest plot, there's virtually no benefit seen across the board for anyone except in those patients who had clinical N2. So when you look at those patients who had clinical N2, the curve is on the left of the unity and the confidence interval is less than 1. So there may be a suggestion that there may be some overall survival benefit in those patients who had N2 disease, probably because it dealt with micrometastatic disease earlier on rather than later on. A long-term follow-up of about 6 years of the same study by Zhang looked at the similar outcomes. There was no benefit across all survival outcomes. But when we looked at the same forest plot for subgroup analysis, the benefit was maintained a little bit for those patients who had clinical N2 disease. So there may be something there, but we shouldn't read too much into it. Meta-analysis of both the studies essentially showed no benefit in overall survival or local regional survival or local regional relapse in either of the 2 studies. In this meta-analysis, in those patients who had oral resectable cancers. However, when you look at the N2 disease, clinical N2 disease, there's possibly some benefit seen in those patients. So you can see that the terminal is on the left of the unity. The p-value is 0.04. However, when you look at the weightage, 97% of the weightage came from the Zong study, which we know showed some benefit, and the patient numbers were extremely small. You're looking at 41 patients. 41 patients. So very, very small numbers of those patients who had N2 disease in these studies. So to summarize, NSCT in resectable oral cavity squamous cell carcinoma, 2 studies at least with very long-term follow-up have failed to demonstrate improvement in local regional survival or overall survival in those patients who are given induction chemotherapy. However, there may be some benefits of it. So mandibular preservation may be seen in those patients without gross invasion of the mandible, reduced use of radiation possibly, disease control in patients with higher nodal stage, so clinically N2 disease, there may be some benefit in survival, and it does help in prognosticate good group from the not so good group. But like I said, that is not a reason to put someone through chemotherapy. Let's look at those patients with neoadjuvant chemotherapy with unresectable oral cancers. Now, the word unresectable is quite tricky. We discussed a lot of this in our MDT as to what is resectable, what is unresectable, and a lot of that is not clarified. It all depends upon the disease status, the anatomical site of involvement, the surgical skills of the MDT team, quality of life issues as to what can be sacrificed, what can't, or what the patient is prepared to let go and what not, and whether you can achieve an R0 resection. So the Patel et al. Came up with some definition of unresectable disease in oral cavity tumors, which is on the right. So basically, if the buccal mucosa tumors have diffuse margins with peritoneal edema going up to the zygomatic arch, tongue primary extend to the hyoid bone or to the vallicula, extension of the tumor to the ITF, infratemporal fossa, or extensive skin infiltration impacting positive margins, or one will not be able to get negative margins once resected. So these are some of the soft signs of what may be defined as unresectable in oral cavity tumors. So let us look at some of the NSCTs done in unresectable oral cavity tumors. Now, the first thing is that if you're going to give chemotherapy, what chemotherapy are we going to use? 2-drug or 3-drug? Okay. We don't have definitive data from oral cavity cancer schema, so we have to extrapolate from other head and neck tumors. So the 2 large studies done looking at 3-drug versus 2-drug to see which one is better was the TAX323 study and the TAX324 study. So this is the TAX32 study, which is published in NEJM, which was a randomized trial done in over 358 patients. Patients received 4 cycles of TPF. So one group received 4 cycles of TPF, and the other group received 4 cycles of PF, followed by chemoradiation. Median follow-up was 32 months. So in this study, there was no surgical arm. So patients were deemed unresectable. Their definitive treatment was decided to be CTRT or radiation, and patients were randomized to receive either TPF or PF. Okay. So incurable stage 3 and 4 squamous cell head and neck cancers. So in this, it is important to understand that oral cavity tumors were only 17%. So only a small number of patients had oral cavity tumors. So patients were randomized into 2 arms and then went on to receive radiation. So in this study, there was no chemoradiation, which is not standard. The standard treatment is chemoradiation. We know from the McKenzie analysis that concomitant chemotherapy with radiation improves overall outcome. So this is not our practice, but in this study, patients were given induction chemotherapy followed by radiation only. And it did show that there was overall survival as well as progression-free survival benefit in those patients who received 3 drugs as opposed to 2 drugs. So median OS was 18 months in those patients who had received 3 drugs and versus 14 months in those patients who received 2 drugs. So the benefit was seen. However, the number of oral cavity tumors were very, very small, and the radiation was not standard radiation. It was only radiation. There was no concomitant chemotherapy in this study. Let's look at the TAX324 study. Again, this was a 500 patient study looking at 3 cycles as opposed to 323, which was 4 cycles. This was only 3 cycles of chemotherapy, TPF versus PF, followed by chemoradiation. The earlier study was only radiation. This was chemoradiation. Okay. Again, like the previous study, oral cavity tumors were only 15%. And in this study, they used carboplatin weekly as opposed to cisplatin, which is our standard, along with radiation. So if chemoradiation was done, it was done concomitantly with carboplatin and not with cisplatin. Again, 2 groups, TPF versus PF. 3 cycles. Benefit was seen both in overall survival as well as progression-free survival. Across both groups, PFS benefit and OS benefit was seen in the 3-drug arm versus the 2-drug arm. So when we look at both the studies together, the both overall survival curves are similar. The hazard ratios are similar, 0.73 and 0.7. Essentially, this these two studies clearly state that if you're going to give chemotherapy in inoperable or unresectable head and neck cancers, 3-drug regimen is the way to go as opposed to 2-drug regimen, because it does result in overall survival as well as progression-free survival benefit. However, not all of them complete chemotherapy. In the TAX-3-2 study, 75% of the patients completed chemotherapy, and in the 3-4-3, it was 3-4, it was 73%. So 25% of the patients do not complete chemotherapy. Toxic deaths was about 2% in the first study and about less than 1% in the second study. So we know it's reasonably safe, but not everybody will complete the stipulated chemotherapy. So knowing that if you're going to give chemotherapy, you're going to give 3-drug and not 2-drug, is there a survival benefit in giving to those patients who are unresectable? Okay, so there were 5 studies done, very large studies, 2 European studies, which is 1 Spanish and 1 Italian, and the 2 American studies, which are the Paradigm and the Decide study. And essentially, of these 5 studies, of these 4 studies, 3 of them were negative. There was no survival benefit. Again, let me take you, these are all done in all unresectable head and neck cancers. But the Spanish studies had 439 patients, but only 93 of them were oral cavity, and there was no benefit with 3 cycles of chemotherapy. Paradigm, 145 patients, again, only 26 were oral cavity, 3 cycles of TPF, no benefit. Look at the Decide study, 285 studies, only 39 were oral cavity, 2 cycles of TPF, again, no benefit. The Italian study, which is the most recent study, had 421, so a very large number of patients. However, only 39 were oral cavity tumors and did show some benefit in those patients who received induction chemotherapy. And we'll look at the study in a little bit more detail. But the other 3 studies we know, we'll look at the hazard ratios, the strips and the p-values, there were basically no difference in those patients who received induction chemotherapy. However, the 2 largest studies, the Decide and the Paradigm, there was small sample size because they were terminated early because of poor accrual. They could not recruit enough patients into these studies. So these are all the studies, both the TAX 3-3, 3-4, and the other 4 studies. And a summary of them, I'm not going to go into all of this, but essentially, it does, all this chart tells us is that if you're going to give chemotherapy, it should be 3 drugs and not 2 drugs. However, it does not benefit our patients in the long run in terms of overall survival or progression-free survival, except in the Guy et al. Study. So let's look at the Guy et al. Study in a bit more detail. Again, it was a squamous carcinoma of head and neck, not just oral cavity, 421 patients, but only 39 who had oral cavity tumors. Patients received induction TPF every 3 weekly for 3 cycles. They were subsequently randomized to chemoradiation with cisplatin and 5-FU or cetuximab and radiation. Those patients who didn't have an induction were straight away randomized to receiving cisplatin and 5-FU along with radiation versus cetuximab and radiation. And this study did show improved overall survival in those patients who received TPF or induction chemotherapy as opposed to those who did not. Okay. The p-value was 0.03. However, the benefit when we split it based on chemotherapy versus targeted therapy along with radiation, the benefit was most seen with targeted therapy and radiation as opposed to chemotherapy. So possibly cetuximab and radiation derives more benefit than chemotherapy with radiation when given subsequently, that is after giving induction chemotherapy. However, when we look at a meta-analysis of all of these 4 studies, along with all of the Japanese studies, the Japanese study here, essentially it shows that there is no benefit. When you look at the overall survival benefit across all of these studies, there's absolutely no benefit of giving induction chemotherapy. And this study also includes the Guy et al. Study. And when we look at the PFS benefit, again, there is no benefit at all in those patients. If you do a meta-analysis of all of these studies. So we know now that in unresectable oral cancers, where surgery is not an option, and we're going to proceed with either radiation or chemoradiation as definitive treatment, giving induction chemotherapy is of no benefit. What about borderline resectable? Now, this is a very, very tricky situation to be in, a borderline resectable. So it's a very, very soft sign. It probably needs to go through rigid MDT meetings to decide whether one can consider a tumor as borderline resectable. So essentially, once downstage, can it then be made resectable? Okay. So there are 3 studies. All the 3 studies are from India, good patient numbers. However, when we're looking at studies, all of these studies are retrospective studies, and we know that retrospective studies are all riddled with errors in terms of evaluation. However, this is the only data we have in our patients. So they are Indian patients with oral cavity tumors. The idea is that can giving induction chemotherapy then make the tumor operable, and does that impact outcome? So let's look at the first study, which was by Rudresha et al. 116 patients or oral cavity. It was a retrospective study. Patients received TPF chemotherapy plus surgery. And in those patients who underwent surgical resection, okay, the median overall survival was 19 months as opposed to only 7 months who did not receive surgical treatment. It's a statistically significant p-value. Median PFS was about 6 months. The other study was a Joshi et al. 110 patients. Again, another retrospective analysis, 3-drug regime was given, followed by surgery. In those patients who underwent surgery, the median overall survival was 18 months versus 6.5 months who did not receive surgical treatment. Again, a statistically significant p-value. We look at the Patil et al., which was a retrospective study again. Induction chemotherapy, they did not specify whether it was 2-drug or 3-drug. It was a retrospective analysis, and all the data was collected for whether they received 2 or 3 drugs. Again, in those, when you look at a 2-year-old survival, 47% of the patients were alive in those patients who underwent surgical resection, as opposed to only 20% who did not undergo surgical resection. Again, a statistically significant p-value. So based on these studies, albeit retrospective analysis, but these are our patient population. So we can presume, okay, for the lack of having high quality randomized control trial, we can presume that in those patients we feel that they can get to surgery, possibly would benefit from some induction chemotherapy, ideally a 3-drug regime for about 3 cycles or so. So this is my summary. This is my take on the talk I'm given. It's basically 3 lines. If you can resect, please resect. That is straightforward. Any oral cavity tumors, if you can resect, please resect. If it is unresectable, can it be downstaged to make it resectable with chemotherapy? If no, then patients need to go for concomitant chemoradiation. There is no benefit of giving induction chemotherapy followed by concomitant chemoradiation because we know from all of the studies that we've discussed that it does not help. However, our own Indian data suggests that if you feel, if it can be downstage and you can then subsequently resect it and probably get an R0 margin or R0 section margin, then it's certainly worth doing some induction chemotherapy, ideally a 3-drug regime for 3 to 4 cycles, depending on whether you take the 3 to 3 or the tax 3 to 3 or the 3 to 4 study. It doesn't really matter, but essentially 3 to 4 cycles of 3-drug regime should possibly be used to try to downstage the tumor. The intention of the giving chemotherapy is then to get the patient to surgical resection so that the outcome can be improved. That is all from me today. I'm quite happy to take any questions.
Yeah, thank you, Dr. Vijay Aggarwal. It is very exhaustive and evidence-based talk from you. And I have a few questions for you.
Sure.
For example, we have, when we get a very advanced oral cavity tumors with multiple nodal diseases, for example, locally advanced tongue cancers with multiple nodes, the surgery would be a morbid procedure. So, would you suggest an NACT to assess the aggressiveness of the tumor, whether it is responding, we can go for surgery. If it is not responding, we can go for a non-surgical treatment. Would you suggest such treatment?
See, so we have to know why we're giving the chemotherapy. Okay. So let us say we're discussing an MDT and you tell me that this is a patient which has extensive nodal disease, contralateral nodes, so N2 disease, okay? Surgery would be quite morbid. So my question to the surgical team would always be that if I give some chemotherapy and I downstage it a little bit, would you still attempt surgery, or are you telling me that this is not for surgery at all? Now, if your answer is going to be no, we're not going to operate on this patient, no matter what, then I would not give them chemotherapy, induction chemotherapy. I'll probably send the patient to go for concomitant chemoradiation. However, you said, no, you do want to attempt surgery, but it's quite large, it's quite morbid, there's an N2 disease, then I might feel that it's certainly worth giving induction chemotherapy to downstage the tumor. We know that there may be some survival benefit, even in operable tumors, patients who have N2 disease, based on the ZON data. Then I'll probably be tempted to say, okay, let's give some 3 cycles of induction chemotherapy, downstage a little bit, but the idea is then to still get to surgery. So the definitive treatment should not change. So that is where I would be my thought process.
Yeah, thank you, sir. Another question, how do you decide the number of cycles? Like whether you give 2 cycles or 3 cycles or 4 cycles? How many cycles would you
So various studies have done various cycles, and we've discussed that during my talk. Anything ranges from 2 to 4 cycles. Now, I do feel 2 cycles are inferior. 2 cycles are inferior, and they were all old trials. So the most recent trials are the TACS 3-3 and the 3-4 trials, in which they use TPF 3 to 4 cycles of chemotherapy. And I think that is what I would stick with. I would use TPF. I would certainly give 3 cycles minimum. The question is whether we push it to 4 cycles. You could push it to 4 cycles, but essentially 3 to 4 cycles of TPF is what I would do.
Okay. Like, we have another question. Like, do you have any experience on using any other agents apart from TPF, like any biologicals?
So it depends upon why. If it's a metastatic disease, so it's if it's not a you're not planning any definitive treatment, then we tend to use cetuximab as well as pembrolizumab immunotherapy now. So immunotherapy has now become the standard of care along with chemotherapy. Historically was cetuximab, but not for induction chemotherapy, not for induction. For induction, it has to be TPF. There is no data to say that adding either immunotherapy or targeted therapy would improve the response rates or improve survival. Clearly, based on the Gee et al. Data, if you're giving TPF, I would probably consider, if you're giving chemo RT, or possibly consider targeted RT, so adding cetuximab with RT rather than chemo RT, but not in combination with chemotherapy to increase the rate of induction.
And sir, would you do you feel neoadjuvant chemotherapy will act as any increase the radiosensitivity of the tumor or something like that?
No, it doesn't. No, it doesn't. So neoadjuvant chemotherapy won't. Concurrent chemotherapy will. So if you are looking at sensitizing the tumor, you want to give it concurrently. See, the idea is that, that is why if you see, certainly in my practice and a lot of other doctors also, when we're giving chemo radiation, we tend to give chemo on early part of the week, so Monday, Tuesday, so that the benefit lasts for the whole week, rather than a Friday or Saturday when no radiation is given on Saturday and Sunday. So it has to be given concurrently to get the radiosensitizing benefit, not before or after the radiation.
Okay. Now we have
some questions in the chat group.
Yeah.
I'll just take some of those questions. Okay.
Yeah, a few questions.
In practice, how do you choose chemotherapy schedule? What factors do you consider? So, like I said, the standard treatment is TPF. 3 cycles is what I choose. So they're either fit for chemotherapy or not fit for chemotherapy. So if they're not fit for chemotherapy, I would not give them induction chemotherapy at all. Okay. Now, and if they're fit for chemotherapy, I'd give them TPF. Occasionally, in practice, I do substitute cisplatin with carboplatin if I'm worried about renal failure or hearing impairment. Okay. But by and large, it is TPF. Yeah. The next question is there any difference between the term induction chemotherapy and NACT? No, it's the same. The next question is, if a patient response to CTRT is good, what is the proposed modality of treatment, CTRT or surgery? Now, I would always prefer surgery if resectable. So based on my talk, I've been quite clear that if the patient has had a good response to induction chemotherapy and you can then subsequently resect, you should resect and not send the patient for CTRT, because those patients who undergo surgery tend to do better. So surgery followed by chemo RT tend to do better than giving RT or chemo RT alone. So surgery would be the way to go. Next question, in patients who have shown complete response after NACT, biopsy being negative post-surgery, would you still recommend surgery? Biopsy negative post-NACT? Definitely yes. So you have to understand that tumor is in a much larger area. Okay, biopsy is taking into consideration only a small part of that area. What we don't know is that the bits have not been biopsied. Are they also microscopically negative? We don't know that. The only way to know that would be to resect the whole thing. So I would definitely recommend that surgery be done even if the biopsy is negative post-NACT. NACT is never a definitive treatment. It is always given before a definite treatment. If you do not want to operate for whatever reason, then certainly give chemoradiation as a definitive treatment. But you should always follow a neoadjuvant chemotherapy with a definite treatment, either that being surgery or chemo RT, irrespective of the biopsy report. Next question is, after NACT in patients with good response, what is the advice to surgeons regarding the extent of surgery with regards to the margin? Now, this is a tricky situation, isn't it? So various studies have looked at various margins, but by and large, the general accepted dictum is that you can use revised margins. If it is resectable, you would have resected it upfront. The idea of giving chemotherapy is to downstage the tumor to ensure that you can then subsequently get a revised, you can get an R0 resection. So I don't think so. If it's a locally advanced tumor and you're downstaging the tumor with chemotherapy, I think you can safely use the revised margins. However, if you have facilities of frozen section, you should make use of that facility of frozen section and keep revising the margin in the theater itself. So that would be my suggestion, but certainly it is not completely clear as to whether you can definitely use revised margins. In breast cancer, it's different. We use revised margins all the time. The data is not that strong, but the data does exist. So if you look at the Reseetable trial, they use the revised margins post-induction chemotherapy, and they did not have any increased recurrence of local regional failure. So I do think that you can use the revised margins. Okay, after NACT in patients with good response, what is advice to surgeons regarding the extent of surgery margin? Could you briefly discuss the patient factor? If age more than 60, contraindication for TPF? No, age is not a contraindication for TPF. It is their performance status. So if someone's got a performance status of 0 to 1, I think there would not be any problem in giving TPF. Clearly, once a patient hits 75, one needs to be careful about that. Again, we should not forget the larger picture as to why we're giving induction chemotherapy. If it is a strong reason that is to get the patient to surgical table, then I think we should try our best to give it to them. If it is just give it and see what happens, then we should probably avoid in those patients who are not of performance status 0 and 1. Will giving NACT prevent chances of disease? Yes, the study from Zong and Licitra did elicit that could be a possibility, though the data is not very, very strong. It was not a primary endpoint or a secondary endpoint in evaluation. It was just a subgroup analysis. So I would not wait too much on that. So that will certainly not be the reason to give chemotherapy. So role of NACT in tongue and mandible organ preservation. So the Reseetable trial did suggest that you can have some amount of mandible preservation if given induction chemotherapy. So there is some data for that. However, there is absolutely no data for tongue. Giving NACT in tongue would improve overall survival or try to preserve tongue with a similar survival outcome. We need some high quality data for that. I know that SCG is doing a trial looking at induction chemotherapy followed by chemoradiation and then subsequent salvage surgery. I think we have to wait for that data. But as of this point in time, there's no data that exists. So it should not be standard of practice, but you could refer the patient to HCG for inclusion in the trial.
Sir, I have a question.
Yes, please.
Sir, when do you do a response assessment after NACT? Like, would you do, like, if you're planning for a 4 cycles NACT, would you do a response assessment after 2 cycles or so, or you wait to complete the whole NACT and then go for an imaging?
Yeah, so my standard treatment in practice is to plan for 3 cycles of chemotherapy. Okay, so I do an assessment after 3. If after 2 cycles, the patient wants to stop treatment for whatever reason, either toxicity or the surgeon says 2 is enough, or because oral tumors are visible, if the surgeon says no, this should be enough, then we could do a response assessment after 2 or 3 cycles. If after 3 cycles, the surgeon still says that no, we want 1 more cycle of chemotherapy to further downstage it, then I go for the 4th cycle, but I don't necessarily do a response assessment after 4. I leave it for the surgeon to decide. So after 3 is what I tend to do most of the time, but I have no reservations to do it either after 2 or after 4.
So then after 3 cycles, how long would you wait to do an imaging? Like, would you do immediately after
3
third
weeks.
cycle?
3 weeks.
3 weeks after 3rd cycle.
Yeah, 3 weeks after the 3rd cycle.
Yeah, thank you, sir. So we have one more question. After NACT and surgery, should we follow it up with RT or chemo RT in the presence of adverse features? That's a question that came.
It's chemo RT. So currently, if you look at the TAX 3-3 and 3-4 study, the 3-3 did not use chemotherapy and the 3-4 uses carboplatin as chemotherapy. So both of them were criticized for not using standard treatment. So chemo RT, we know from McKinsey database analysis that is the standard of treatment. So just because we've given neoadjuvant chemotherapy, we should not compromise on definite treatment. So definite treatment, if that is going to be surgery followed by chemo RT, that should remain the same. That should not change. Clearly, if someone has renal compromise or hearing impairment, because of the induction chemotherapy that you've given, you might want to modify that and either use cetuximab with radiation, or though the data does not exist adjuvantly, or you could use carboplatin in 5-FU or carboplatin with the chemotherapy, but you certainly give some sensitizer with radiation. So role of NACT in HPV. So it's difficult. We don't know the relevance of HPV in oral cavity tumors. We know it has relevance in oropharyngeal tumors. So I'm going to pass that question because I have no idea. We do not do HPV in oral cavity as routine or decide on treatment based on HPV status in oral cancers. We do sometimes do it for oropharyngeal, but not for.
Right. I think that all the questions now have been covered, sir, and thank you for the wonderful presentation. I think you really broke it down well for all of us listening in into resectable, unresectable, and borderline resectable. These are the looking at it from that perspective really gives a lot of clarity into when and where NACT can be used. I think we have another question, sir, if you're willing to take it, on the RECIST criteria for assessment post NACT.
So what's I can't see the question.
The RECIST criteria of assessment post NACT, so the imaging criteria.
Yeah, so we use RECIST 1.1, but in induction chemotherapy, it's the surgeon's assessment that matters, not the radiological assessment. So if the surgeon feels that it's resectable, we go for surgery. If they still feel it's unresectable, then they go for chemo-RT. But in terms of response assessments, either it's induction or it's metastatic, doesn't matter. RECIST 1.1 is what is used.
We have one more question, sir. How do you decide on giving NACT? Is it based on size of tumor, or is there any change in depth of invasion post NACT?
It's neither of those things. It's based on resectability. So like I said, if it's resectable, you don't give NACT. If it's not resectable, that's when you start thinking, should I give NACT to make it resectable, or we presume it's never going to be resectable and go for chemoradiation? So it's in the first one. If the surgeon tells me that, can you downstage it so that it's less morbid? Like Sudesh asked me, if it's an N2 disease, it's quite morbid, large surgery, can you downstage it so that I can do a better surgery? Yes. But if he tells me that, no, this is not operable, it's gone to the ITF and it's involving the masticator muscles, so I'm not going to be able to operate at all, then there's no role for induction chemotherapy, then they go for chemo-RT straight away. So it is not based on the size and the depth of invasion, it is based on resectability. Can you get an R0 resection or not? If you think with downstaging you can get an R0 resection, give them induction chemotherapy. If you think you're never going to get an R0 resection, then there's no point in bothering with NACT, just go for chemoradiation. Shalini, you're on mute.
Yes, sir. Yes, sir. So I think that's all the questions that have been asked in the chat box. The one on RECIST criteria was asked to me privately. I think there's one more. If there is a good response after 2 cycles, can we then take him up for surgery, or would you like to give the 3rd cycle as well?
Certainly. Like I said, the idea of giving chemotherapy is to downstage to get them to the surgical table. If the surgeon is happy after 2 cycles, there's a good response, they can operate, please go for it. I would prefer that. Certainly the toxicity would be a lot less giving 2 cycles versus as opposed to 3 to 4 cycles.
Right, sir. Thank you so much, sir. Thank you so much.
I apologize again for the hiccup because the light went off, but it all went good. Thank you very much.
Absolutely not, sir. Thank you so much for joining us today. Thank you, Dr. Sudesh, for doing a wonderful job of moderating the session. And I think, initially when there were no questions, you really brought on a good discussion. Thank you so much, sir, for all your efforts. Thank you, Vijay sir, for joining us today. I mean, like I said at the earlier, you really broke it down and gave us a lot of clarity. Neoadjuvant chemotherapy is something that we are not very sure of, and when we deal with oral cavity cancers, we are not always sure of when and how we can use them. So thank you so much for joining us today. Please join us this Saturday again for another session on ITF tumors by Dr. Neerav Trivedi. This is streamed live on Facebook, and the videos are also available on our YouTube channel. Please subscribe to them for regular updates. Thank you so much, everybody, for joining in. We'll see you next on the Saturday session. Thank you.
Thank you. Thank you very much.
Thank you, sir.